In 2022, Counterweight, the organization that Helen Pluckrose founded and that was absorbed into the Institute for Liberal Values, had a virtual conference on liberal approaches to diversity and inclusion. Starting in 2025, we will be rolling out one talk a month that was presented at the conference. We sit down with the original presenters throughout 2025 to see what has changed since 2022. With diversity, equity, and inclusion initiatives seemingly on the chopping block, we are curious to hear what our original participants are witnessing and experiencing on the ground. Is DEI really dead or just in remission? Are there healthy alternatives to DEI that we should consider, or do we throw the baby out with the bathwater and wipe our hands clean? What do you think? Share your thoughts in the comments. This month, we share Zander Keig's original presentation to the conference. You can find our podcast where we check in with him in the present day to find out how things have changed, entitled In Search of a Third Space in Trans Care and Conversation, in the show notes. Zander Keig, welcome to the Counterweight Conference on Liberal Approaches to Diversity and Inclusion. It's wonderful to have you here and share your knowledge with you. I love the work that you do, and I know today you're planning on speaking on contemporary issues within trans care. And so with that, I'm going to let you just go ahead and tell me more.
Sure. Well, thank you. Thank you for the invitation. It's wonderful to be able to present for the Counterweight Conference. So for people who don't know who I am, I'm Zander Keig. I'm a licensed clinical social worker. I live in the state of Florida in the United States. I'm a trans man. I medically transitioned starting in 2005 with hormones. And I'm also, as a clinician, I've not only done psychotherapy as a gender therapist, I've also worked in case management with transgender service members in the U.S. military. And am currently working as a faculty member and a mentor or consultant with two different certification programs that provide training and education for people that are seeking to become either gender therapists or more familiar with how to work with trans clients and patients. So that's a little bit more about me. As a social worker, I've been doing a workshop for a couple of years now at social work conferences and also through virtual means for social work students and people who are recent graduates of social work programs working on continuing education credits. And what I was mostly focusing on was this idea of how can we as clinicians provide culturally and linguistically appropriate services to our transgender patients and clients? And so the idea for this comes from here in the United States. The U.S. Department of Health and Human Services has something called the Cultural and Linguistic Appropriate Standards. So these Health and Human Services Cultural and Linguistic Appropriate Standards are broken up into 15 action steps. And so the action steps are broken up even further down into three main categories, so to speak. So you have governance, leadership, and workforce. You have communication and language assistance. So that'd be things like having interpreters and translated documents, things like that. And then there's engagement, continuous improvement, and accountability, right? Making sure that at all level of your organization that things are culturally and linguistically appropriately serving clients. And I thought, well, I wonder if I could take those standards and I can adapt them to servicing, transgender clients and patients. And so that's what I've been doing. I've been doing a training like that for the last couple of years. And recently I was asked to talk about some contemporary issues at the end of this training. And so what I thought would be interesting for this discussion would be to focus on some of those contemporary issues as I understand them, like my experience as a trans person walking through the service, and all to the service provision and also as a provider of those services, right? Like talking about it from these different perspectives. And so what I want to make sure is that we're working with some similar language. And so when I talk about things like transgender, I'm using that in a very, very broad sense. And that is incorporative of people who are transsexual and people who might be gender fluid, right? There's a lot of different identities. Some people might even just call themselves transgender, right? Transgender could be like this umbrella term as it's typically referred to, but there's so many different categories of people, right, under this umbrella. And so when we're talking about that, it's like, well, how do we look at all these different people in a way that we can somewhat make sense of it, right? From this clinical viewpoint, right? And so what I do is I tell people, like, I talk about something called the social identity matrix, right? That we all have a chromosomal sex, right? I'm a trans man. My chromosomal sex is female, right? So I'm a female who lives in the world socially as a man. And in the United States, legally, I'm also regarded as being a man, right? That's what my ID says. It says male, which is, not 100% accurate, but you get, people understand, right? There doesn't say man or woman on government ID. It says male or female. So it's a I've heard somebody refer to it as like a legal fiction, right? But it serves a point, and I'm not gonna quip with that. Although some people in the trans community might have a really difficult time with that concept. And then there's this idea of gender identity, and gender identity it says that it's a socially constructed thing. That our gender identities are socially constructed, but the whole idea of gender identity is also socially constructed, right? So, but people talk about it as if it's this real thing, like very concrete, like a natal sex or a biological sex or a chromosomal sex. But it's not, right? It's a social kind of thing. And so that's why I could say, like, I live in the world as a man. I don't identify as a man. I'm just living in the world as a man. I identify as a person, as a human, as Zander, right? And so, but some people have an identity of their gender, and a lot of people would be working with trans people who do have a really strong identity. But then there's gender expression, and we all have that. My beard is an expression of my masculinity. Not all men have beards. That doesn't mean they're not men or masculine, right? But for me, this is how I express myself. For some people, it's the clothes they wear. For other people, it's the music they listen to, the way they style their hair. For those who still have hair, right? So that's gender expression, and everybody has that. I mean, you have it. You style your hair in a particular way. You dress in a particular way. You probably have a particular, color pattern to certain things, right? It's like we're expressing our gender through that. It's very personal. And then there's sexual orientation. Everybody has a sexual orientation. You're either heterosexually oriented, homosexually oriented, bisexually, asexually, meaning, not really sexually interested in anybody, right? And there's a bunch of other terms that people have probably heard of. So I refer to that as a social identity matrix. And so for some people, more of these components are more important than others. Right. So for me, chromosomal sex is more important than gender identity. For some people, gender identity is more important than chromosomal sex. For some people, their gender identity supersedes, and they believe it's the only accurate representation of themselves because they don't believe that chromosomal sex even exists. Right. So that's just, and people watching this and listening to this, they may actually be working with people like that. Right. So just to keep an open mind. That doesn't necessarily mean that they'll continue to work with people like that. We do have agency as clinicians to a certain degree of being able to refer people to others, if the need arises. So when we're talking about how to use appropriate, right, or accurate, or maybe respectful, right, terminology, well, how do we do that in this rapidly changing, ever evolving community, right? It's like, are you to believe that the terms that you're hearing on Twitter are reflective of all trans people around the world? That the words you're hearing via Twitter should also be applied to someone like me, right? I call myself a transsexual. You might be told by people in your life that transsexual is a derogatory term that shouldn't be used. Well, I say, well, I use it. I don't consider it derogatory. Now, would I call somebody else a transsexual? No, I would not, unless they told me they were transsexual. So that's what I mean by respectful and appropriate. I'm not going to call somebody a word that they don't want to be called. I also don't want people telling me I shouldn't call myself a word that I call myself because somehow it's problematic somewhere out there, right, in the world. And then there's also things that have to do with if a person is not transsexual, well, are they transgender? And what does that mean? Are they gender nonconforming? Are they gender incongruent? Are they gender diverse? Are they gender fluid? Are they gender queer? Are they non-binary gendered, right? Like there's so many different ways in which people refer to themselves. And so right? It's just a good thing to know. We're not a monolith, and so we use different terms based on where we've grown up, what faith we practice, the kind of family system we're in. There's a lot of reasons for that. And so what I typically advise clinicians is that we take into consideration, right, what it is our clients or patients are telling us. Like, what are the terms they're using to describe their anatomy, their identity, their relationships, their experience? What words are they using? And we can do our best, right? Due diligence to be as respectful as possible. And if we find that there are certain things that we have difficulty saying, then we just find an alternative. So, for example, pronouns is a big thing, right? That's a contemporary issue, pronouns. So, one group of people would say, if you don't use the pronouns exactly as people request them to be used, then you are transphobic. You're a hateful person. For some people, they just don't want to. They don't agree with compelled speech. And as an American who is very, very proud of our tradition of free speech here in our country, I don't want to compel anybody to say anything that they don't want to say, nor do I want to provide an environment where people have to squelch what they want to say, right? So what we can do instead is we can use somebody's name, right? So if we don't want to use a neo pronoun like ze, zer, or use the more common they, them, we could just refer to a person that we're working with as a client by their first name because they're in the room with us typically, right? When we're doing charting, note taking, right? I tend to write the client, the client, the client, or the patient, the patient. I don't use pronouns or their name, right? So I sort of I use those more generic terms, right? They would be considered gender neutral, so to speak. So, I'm not saying take the lead of your client. I'm not saying affirm your client because I know that's an issue. And I'll talk a little bit about that, this idea of affirmation with patients and clients. But to a certain degree, we can be respectful and we can treat people with dignity. We are bound by that in our ethical codes. Our ethical codes mandate that we are respectful, we treat people with dignity, and that we're professional. And so, and that we don't bring our own personal bias and agenda into the therapy room, right? Or into the practice room, that we seek consultation if we're having countertransference issues, right? We don't bring that in. We don't bring it in either to dissuade or persuade, right? And I'll talk a little bit more about that. So one thing I wanted to talk about was right in the middle between these two main topics that I'm going to talk about are this idea of health literacy. So it rarely gets talked about. And when we're talking about healthcare in general, but when we're talking about trans healthcare, especially with children and with teenagers, where the parents are making a lot of the decisions, but even with young adults and adults of all ages, I don't know about in countries outside of the United States. I should have done that research. I did not do it. I'm US based and I do most of all my trainings basically here in the US. So I have US data, and there is such a thing as the Health Literacy Lab here in the United States, and it's associated with the university. And they have found that about 50% of the adults in the United States read it about the 8th grade level or below, right? The 8th grade level or below. And that might sound a little bit high, especially considering in some parts of the world, people don't even go to school or they don't go past 3rd or 4th grade. But in the United States, where we have government schools and going to school is a law, right? You have to go to school, right? We have people who are going all the way through high school, and they half of them can't read above the 8th grade level. And so what that means is that that's like everyday reading. But when you take it one step further and you look at scientific writing, only about 20% of adults are science literate in the United States. 20% of adults in the United States are science literate, and medical information is scientific information. So when people are talking about diagnosis, when they're talking about medications, when they're talking about dosages, when they're talking about surgical procedures, when they're talking about pre-op and post-op care, that's all medical information. And if only 20% of the adults in the United States are science literate, then, and we're expecting that people are hearing what's being said to them, they're reading what's being provided to them in literature, and they're signing a document that says informed consent, well, chances are they're not fully informed, because 80% of them might not actually be understanding what they're reading and what they're hearing. So they're basically just signing a piece of paper, and most of the time they're not even reading it. So are people truly informed? And if they're not truly informed, how can they consent? That's an issue that I bring up when I'm doing these trainings. So I typically advise the clinicians, these are social workers for the most part, who are a lot of us have our foundational training is in a type of like medical social work, right? So many of us have the ability to break down terminology. We have the ability to elicit from our clients and patients the demonstration that they actually do understand, that they are being informed, and they are able to consent. And so I think that that's something that we should be, I don't consider that gatekeeping. I consider that being ethical in wanting to make sure that our clients and or patients actually understand what they are reading and what they are being told, and from their providers, but also from their peers. There's a lot of peer information via the internet, via support groups, a lot of different, right, reading books. And so we need to just make sure. So that's one issue, right? That's, for me, that's a contemporary issue, because I don't think anybody was really paying attention to the health literacy of our patients and clients. I don't think most providers are paying attention to that. And so then another contemporary issue has to do with viewpoint diversity when it comes to how to treat, right? How to treat our clients and patients, not like, are we respectful or disrespectful, but really like how to diagnose them and how to write a treatment plan and how to construct goal setting, these kinds of things, right? The treatment of our patients and clients. And so, what we're dealing with mostly in most Western societies, it seems, I'm not sure what's going on in some other societies, around this idea that there's this orthodoxy, right? And it's coming from on high somewhere. It's coming from, trans professionals who are they themselves medical doctors, college professors, writers of sorts, right? And so they're researchers. So they're doing research, and then other people are publishing the research, and other people are writing books, and some people are teaching classes, right? And so you've got this like class of professional trans people, and then their allies, right? So people in all those professions who aren't trans themselves, but are allies, right? Allies to the trans community. And so they just push this information forward. And so if anybody has their own thoughts about something, right? If you're a free thinker, right? You're a heterodox thinker, then you can find yourself on the short end of patience and respect, and of kind treatment, right? So as a trans person myself, who's a clinician, if I encounter these kinds of orthodoxies, and I as a heterodox person sort of go, well, my experience is different, or I think this, or I'm really curious about this, instead of people engaging with me on a like, that's interesting, tell me more about that, or, oh, well, this is how I came to my conclusions, how did you come to your conclusions, I just get labeled as a transphobic something, right? Fill in the blanks. And so that's why I thought this would be interesting to talk about this, as like how a trans person who's a clinician who does education and it works in the community, like, how do I become transphobic, right? It's like, for you, if you're not part of the trans community, you get labeled as transphobic. It's like, well, you're an outsider, I'm an insider, right? And so it's just bizarre what's happening. And so what's happened recently is that some of these, quote, high ranking people in the trans community who are doctors and professors and clinicians, right, at the doctoral level, psychologists, they are speaking up, and they're speaking out, and they're raising concerns. And even some allies, people who have been part of the community as far as being stewards of assisting us navigating this sort of convoluted system of getting access to, trans care services. They've been there all along for, a decade or two or more. And so now they're starting to go, wait a minute, something's not right here. And so there are some particular names. I'll raise some names, during this training, just to give you an example. So two people that are part of the community that would be considered sort of high up in visibility and also power, right? That's an important piece of this. So one is Dr. Marcy Bowers. If people don't know who she is, she's the incoming president of WPATH, the World Professional Association for Transgender Health. This is a global organization that has been in existence since 1979. It's on the web at wpath.org, and they write what are called the standards of care. We're working off of version 7 now. Version 8 is just about to be released. It's in the final stages of that process. And so Dr. Marcy Bowers is a transsexual woman. She's also a gynecologist who's been doing what some people call sex change surgeries or sex reassignment surgeries or gender affirming surgeries. See, this is about the linguistic, right? The linguistic stuff. It's called different things around the world. And even here in the United States, it's called all those things, right? And so she does those surgeries, in particular one called vaginoplasty, right? So she works with people who are male sexed, in my worldview, not theirs necessarily, and they go to her for surgeries, right? And so what she sounded an alarm recently because she said, listen, if you put a child who is presenting with a gender incongruent expression to their natal sex, and you think, oh, this person should not go through puberty because they're probably going to grow up to be a transgender adult. We don't know that to be true or not, right? You put them on these things called puberty blockers, right? So puberty blockers is another one of those contemporary issues that are very controversial right now. So you put them on these medications so they don't go through puberty. And now she's seeing these kids, these young adults, older teenagers, young adults, who were put on these blockers. And then at a certain point in time in their adolescence, they were put on the cross-sex hormones or gender-affirming hormones, right? Or hormone replacement therapy. It's called different things, different places. And what happens is, since they didn't go through puberty, and we're talking about natal males, they didn't go through puberty. And now they go to see Dr. Bowers to get this surgery, vaginoplasty surgery. Well, vaginoplasty surgery is where they take the external penile tissue and they invert it into a canal in your body cavity. Well, if you don't go through puberty as a male, your penis doesn't grow beyond that of what? A toddler or preteen? I don't know, right? Pre-pubertal penis length. Well, that's a very, very shallow canal. Now, for some people, that wouldn't matter because maybe they don't want to have vaginal intercourse. Okay, that's fine. There are a lot of adult transsexual women that are getting actually what they call no depth, which is a misnomer. It's about a 1-inch depth vaginal canal because they don't want to have vaginal intercourse. So we can't assume that all people want to have vaginal intercourse, but a young person doesn't know whether they want to have vaginal intercourse or not. They've never had it, right? And they've probably never even had sex because puberty blockers disrupt sexual, that sexual feelings in us. That's what hormones do. One of the things they do is they make us, feel sexually aroused. So they don't go through that period in their adolescence, right? Until they go on the cross-sex hormones, and then they're going to feel that. And so her concern is that, one, we're making these kids infertile. That's what she says, because if they don't go through puberty, they're not going to be producing sperm. And also with the natal females, they're not going to be, I don't know, what's the way to talk about it? Germinating the eggs, right? Like, you know what I mean? Like, so they're not, right? They're not going to be viable. They don't have viable sperm. They don't have viable eggs, right? Their gametes are not functional. And so they become infertile because you can't take eggs or you can't take sperm or eggs out of a kid who hasn't gone through puberty and bank them. It won't work, right? And so, although I don't know if that works for eggs or not, but it won't work for sperm, right? And so the issue here is they're infertile. They probably have never had any sexual experience. And now they're coming for a surgery and they don't have enough tissue, right? They don't have enough tissue for the standard surgery. And she is sounding the alarm about this. She thinks people should be paying attention to this and that maybe we shouldn't be putting kids on blockers. That's her opinion as a medical doctor who does vaginoplasty surgeries and is a transsexual woman who's about to become the president of the Global Transgender Health Professional Association, right? That's been around since 1979. Well, she sounds quite credible to me, right? So I'm not going to outright dismiss her, but she is outright dismissed by her colleagues and by more activist members of the trans community. But I don't outright dismiss her. I don't agree with everything she says about everything she has talked about, but so what, right? I respect her as the clinician and the person that she is. Another is Dr. Erica Anderson, also a transsexual woman, also here in the United States. She is a psychologist. She's been working as a psychologist for about 40 years. She's been working with trans people for, I think, about 30 of those years. And in particular, I think in the last maybe 15, 20 years, she's been working. Actually, you know what? I don't know how long she's been working with adolescents, so scratch that. But she's been working with adolescents more recently, right? She was a psychologist at the gender clinic at the University of California, San Francisco Children's Hospital. And she again, so she's a transsexual woman. She is a psychologist. She works with trans clients. She worked in a gender, quote, affirming clinic. She's also the outgoing president of USPath, and USPath is the United States chapter of WPATH, right? So WPATH is a global professional association. There are chapters around the world. There are regional chapters. We have one here in the United States. She was the president of that board. She was the like almost president for 2 years. I don't know what you call that, the president for 2 years. And then she resigned before fulfilling her term as the outgoing president for 2 years. She resigned. And so you have this experience where, you know, one person was actively the president of USPath, and she spoke. She was interviewed by Abigail Schreier, and who put out an article through Barry Weiss's Substack, talking with Dr. Erica Anderson and Dr. Marcy Bowers. Erica Anderson was also interviewed by writer for Quillette, and she, along with another psychologist, an ally, a non-trans woman who was one of the founding providers at the Children's Hospital in Boston, who was the first hospital for children in the United States to use puberty blockers. She was part of the team that introduced that to the United States. She joined Dr. Erica Anderson, also as a psychologist, in penning an opinion piece that was published in the Washington Post. So now you have these people that are quite credible, and they have been in the community, working with the community, part of the community. They're professionals. They're in this large professional association. As a USPath president, Erica Anderson sat on the WPATH board of directors, right? So these are very credible people. Dr. Laura Edwards-Leeper is the psychologist who worked at the Children's Clinic in Boston. She's also very credible because she said, oh, you know what they're doing over, the Dutch people, what they're doing with puberty blockers, it looks really successful. Let's bring it to the United States. And of course, for a lot of people, they're already going to know that they're starting to pull back on using puberty blockers now in countries all around the world, like Sweden and Finland and France, right? Britain temporarily. I'm not there in some court case right now, so I don't know what's going to happen there. But here in the United States, it's a raging battle, and you are either orthodox or you're heterodox. And if you're heterodox, then you're the enemy. And it doesn't matter if you're trans, and it doesn't matter if you're part of this global professional association, and it doesn't matter about all the wonderful work you do in the world. You are the enemy. And so I've been tagged as the enemy, right? I mentioned that briefly. And so in 2020, I was given an award by WPATH as the Educator of the Year. The official title is the Harry Benjamin Distinguished Educator of the Year, right? So that's a big deal. And because of that, and also I'm on faculty with the WPATH Global Education Institute, so I teach classes through them. I used to. I've sort of been not being invited anymore to these things. But so this is part of the issue. But I was appointed, or I was given the position, so to speak, of being a chair to a committee for the US Path chapter. And then I affiliated myself with a transgender organization based out of Canada called the Gender Dysphoria Alliance, which was founded by trans men. The primary founder is a psychiatric nurse, right? Like, so we're talking about a professional within the field who has worked with trans people, is trans himself, founded an organization to look more deeply at this thing called gender dysphoria. What does it mean? How's it manifesting in the world? What are people's opinions about it? What are all the different ways that people are responding to gender dysphoria? Well, his organization has been deemed, right, wrong. And so, as a person who affiliated with that organization, it was just for a short period of time, because in some ways I caved. I revoked my membership, so to speak, with that organization, because I didn't. The harshness that was the harsh criticism that was coming towards me was a little overwhelming at the time. I should have just stayed involved because, it died out. But I was removed as chair of that committee. And there's no recourse for that. I can't appeal it. I can't find out why. I was just deemed inappropriate and removed. There's no recourse whatsoever. Right? So we find ourselves as trans people who are professionals and providers and members of this community being ostracized and being, problematized, right? And so, for example, like, I said, I'm on faculty with the Gender Education Institute at WPATH, but in the last year, basically in the last year, everything went virtual because, in the last 2 years because of COVID, but I was still being invited to be on live panels that were being done via, virtual video, and they've stopped inviting me now to those things. So I'm not invited to be part of the faculty that's working. I'm on the faculty list, but I'm not being engaged, right? And so maybe this has something to do with that. I don't know. I have requested information about it, and the response is, I wouldn't call it hostile, but there's a tone to it, right? There's a tone to it, which is, basically telling me, like, stop asking. Stop asking. That's basically the impression I'm getting. And so that's a really interesting contemporary issue. Trans people are coming out and saying, we think there are some issues. So Dr. Erica Anderson, her main issue as a psychologist is that she thinks, and in her words, I think she used shoddy assessment, right? That's in Abigail Schreier's Substack article. I think that's the word she used, was shoddy, right? And so what she's saying is people are too easily and too quickly being passed through the biopsychosocial assessment component on their way toward getting access to hormones and surgeries, that people are either able to bypass that altogether, or they're being pushed through so quickly that nobody's really observing or assessing for things like, well, what's your support system? Like, how are relationships with you and your family? Are you stable in your job? Are you stable in your housing? What resources are you connected to in your community, right? Your trans community, your geographic, right? Your neighborhood, your city, your state, right? That's what a biopsychosocial assessment does. It determines, like, what are your strengths and what are the areas where you need support. Now, it's possible that they also have comorbidities, right? Co-occurring mental illnesses like anxiety disorder or depression or something like that. And maybe psychotherapy would benefit them. Not all trans people need psychotherapy, but that doesn't negate the fact that we need resources and we need support and we need access to these things. And who better to provide us with that access but the professionals who are networked in their communities, right? On the ground and professionally, to be able to provide us a warm handoff or a linkage to a person or a program or a service provider, right? And so when people are being just sent straight through to get hormones and surgeries, they're going to have to acclimate to a new social reality that they may or may not be prepared for, that they might not have the skills and the resources to be able to navigate, right? Going from being a masculine woman like I was to being, right, perceived as a masculine woman to now being perceived as a man. Well, the world treats me very differently. And I didn't know how differently I would be treated until I started being treated differently. And I was so discombobulated and disoriented. And I really could have benefited from speaking with perhaps a therapist or a coach, somebody other than a peer, because there's only so much we can get from our peers. Right. And so I think that it's important that people go through this biopsychosocial assessment. Again, that's not the same as psychotherapy, and not everybody needs psychotherapy. But if they do need psychotherapy, now we're getting into another, contemporary issue that's controversial, which is what kind of psychotherapy, right? So there are three basic buckets, so to speak, that I hear people talk about. And one would be considered gender affirming therapy. So there is a gender affirming therapy model. There's a textbook, or not, it's probably not even a textbook. There is a book written by two psychologists. One of those psychologists is also now a medical doctor, as a trans man, or maybe not a trans man, but member of the trans community, right? And so this book was written at the time by two psychologists who were like, this is how you can work with your trans clients. It's called gender affirmation. That's a particular model. The American Psychiatric Association says gender affirming therapy is a therapeutic stance that focuses on affirming a patient's gender identity and does not try to, quote, repair it. Well, where does this language come from? Repair. Well, that comes from another kind of therapy, another bucket, so to speak, reparative therapy or conversion therapy, which is more familiar to people, right? And so conversion therapy is looked at as putting in interventions which are trying to alter a person's sense of self around their sexual orientation and their gender identity. So a lot of times people who practice conversion or reparative therapies, a lot of them are coming from more of a religious background, and they're trying to relate to people like, this is not what God wants for you, right? This is not what your family wants for you. And so they do all kinds of things. Some of it's psychological, some of it's medical. Like they'll hook people up to electrodes, they'll make them watch pornography, right? And then they'll chastise them for their arousal, right? Of same-sex interactions or stuff, right? So it's stuff like that. So it's considered to be harmful, right? And unproductive, and in a lot of cases, not successful. And in many states, it's illegal, right? With children, at least. Now, adults can make the choice that they do not want to be a gay person or a trans person and seek out conversion or reparative therapies. I mean, I wouldn't do that, but adults can make up their own minds about things as long as they are not under the guardianship of somebody. They get to make those decisions. But most of the time, people think of therapy being affirmative or conversion, right? Reparative or affirmative. But there's also this idea of exploratory, right? So there is an organization called the Gender Exploratory Therapy Association, and they take a stance that's more like where you focus on the client, right? Their wish to deepen their own understanding of their gender-related distress, right? This comes right off of their website. That's why I was reading it, because I want to make sure I got it right. It's like, okay, so you'd say to a client, oh, so you identify as trans, okay, and well, what does that mean to you? And are these ideas that just came into your own head, or do you see them somewhere? Did you read them somewhere? Did you hear them somewhere, right? In what way is your family reinforcing or not these ideas, right? Like, are these based on your rejection of gender roles for your sex in society? Are they based on the expectations of you within your faith system or your cultural system, right? Like really exploring where all these things are coming from. Nowadays, a therapist who works with trans people questioning their gender identity, so to speak, also, if they are using an exploratory or exploration oriented therapy model, they would be deemed conversion or reparative therapists because they're not, quote, affirming. And what a lot of people mean by affirming is agreeing with and just passing along to the next person in the right in the system. Hormones, there you go, pass on. Oh, you're trans? Okay, here, go to the doctor, right? Exploratory therapists are also going to be affirming. They're going to say, oh, what I hear you saying is that you believe yourself to be a trans person. I'd love to hear more about that, right? It's not affirming. A non-affirming stance would be to say, well, we need to talk about this because that's just crazy. Or there's no such thing, and you should stop talking about that foolishness, right? That's more of a reparative or conversion therapy angle, right? Excuse me. What you think you are is wrong. What you want to do is wrong. That's not what exploratory therapists are doing. So there's just a lot of disagreement around these issues. Should we or shouldn't we be putting kids on puberty blockers? And nobody wants to talk about the long-term consequences on the physiology of the body of that person, the mind of that person, the emotional development of that person. Nobody, and their social involvement and development. People don't want to talk about it because they're looking so narrowly at it's saving them, it's rescuing them. If we don't give them blockers, they're going to kill themselves, right? That's what people get told. Parents get told, do you want a dead daughter or a living trans son? It's like, well, that's blackmail, right? That sounds like a narcissist talking, right? Holding people hostage to they decided they're the judge of all things, right, for that family. So let me just wrap up and say that even the Endocrine Society says that there's just not enough data available to truly know what the benefits and risks are of puberty blockers. So we should be paying attention to people and systems that are credible. I consider the Endocrine Society to be credible when it comes to talking about puberty blockers, right? So let's do some research. Let's have discussions about this. That doesn't mean that as providers that we shouldn't be respectful and treat our clients and patients with dignity, right? Or our students, or our family members, or our neighbors, or our peers, our colleagues. We should be treating everybody with dignity and respect, up until the point where they're about to, bash us over the head, or, right? We should be doing that as professionals. It's part of our ethical codes, and we should be adherent to those ethical codes. We should also be paying attention to the health literacy issues, right? Again, 50% of people in the United States, sorry, I don't have other data, cannot read beyond the 8th grade level, and only 20% of people in the United States understand basic scientific terms and concepts. Transness, almost all of it is based in science, medicine, psychotherapy, right? Surgeries, these kinds of things. So we should be helping our clients and patients and people that are in our sphere of influence to understand the health and the science information that they are receiving and accessing. And also to just know, it should be obvious by now, not just from my presentation, but from all of you who have been paying attention, that the trans community, again, is not a monolith. I actually wrote an article about that for the Foundation Against Intolerance and Racism on our Substack, which, interestingly enough, I didn't get much blowback from that, but maybe I did, but I'm not on social media, so I didn't get to see it, thankfully. But we are so different as people. We come from different geographic locations. We were raised in different kinds of family systems. We have different races, different cultures, different ethnicities, different religious backgrounds. We come from different socioeconomic backgrounds. We are very, very different people. And so we shouldn't all be treated the same. And if one person is going to be very, very sensitive about how people refer to them, I say, do the best you can, and hopefully they'll find another provider that will serve them better. But it doesn't make any sense, and it's not appropriate or professional to mislabel people, refer to them in ways that are going to just get them all upset, right? That's not how we should be treating patients and clients. But that also doesn't mean that we must be compelled to use words we don't want to use, and that we shouldn't be squelched from speaking when we're speaking, like, say, like I am now, right? I'm outside of the therapeutic setting. I'm doing a talk for, academics and providers and interested peoples. So, yeah, so I'll end there. I'm sure there are some questions, so let's jump into the questions.
Yeah. One of my biggest questions for you is you gave your perspective from a clinical and therapeutic environment, and I'm wondering, when we're in a organizational environment, workplace or school or
Yeah.
whatever, and you're involved in the diversity training, you're engaged in trying to bring in these diverse ideas. The biggest thing that I got from you was what you ended on, and you also kind of started on, was this idea of, how do we marry ideas of free speech with respect and dignity? And I thought your
Hmm.
solution was very elegant. Like, if you have a problem with pronouns, for example, which was the example you gave, using a name instead,
Hmm.
would there be anything else that you would add to that, not, that's outside of the clinical setting and more like in a workplace or an organization setting, to deal with these issues around diversity and inclusion with regards to trans issues?
Absolutely. One of I don't work as a psychotherapist anymore. I'm actually a emotional wellness and personal growth webinar facilitator and a DEI trainer. So this is what I do. I work on with the Fair Diversity team at Foundation Against Intolerance and Racism. And so one of the things that we do is we go into corporations. Well, it's a lot of virtual now. And what we do is we do a pretty large part of our training focused on cognitive bias, right? Not implicit bias, cognitive
Mm,
bias, and how
okay.
we all have cognitive bias because it's just little shortcuts that our mind does, right? And so we put people into these big groups: Black people, gay people, disabled people, trans people, right? White people, right? We put people into these big buckets, and then we use stereotypes, and then we flatten them into that stereotypical, right, monolith, and then we dehumanize them by not acknowledging their individuality and their agency. And so it'll happen in a clinical setting. It happens in an occupational setting as well, right? Because, for me, I was talking about, like, as a trans person, as a provider in these professional associations, we're talking about colleague, right? Like peer to peer in our workspace, right? But in a
Mhm.
corporate workspace, a university web space, or excuse me, um, uh, uh, like a physical space, at work, at the different settings. Sorry, I got a little tongue tied
Mhm.
there. Um, it starts with making sure that we're checking ourselves first, right?
Mm,
Because
mm,
since we all have cognitive bias, right? And since our brains have these mental shortcuts, and the reason we have these mental shortcuts is because we would be too bogged down every minute of every day if we had to hold in our brain every bit of information we've acquired over our lifetime, right? So our brain goes, oh, I remember that experience, and this is what the outcome was, and it sends a little synapses, little circuitry there, right? And so we can override that. We can relearn, right? That's what plasticity is, right? We have neuroplasticity. If we pay attention to what our cognitive biases are, and there's a whole bunch of them. And when I was doing psychotherapy and as I do psychoeducation, I teach about these things because when we have these cognitive biases, that's makes it more difficult for us to tolerate distress, regulate our emotion, and manage our stress, right? And if we're not able to do those things, that's going to make our relationships in the workplace, in our home, in our communities much more difficult, conflict ridden spaces, right? And so the idea, right, as a more heterodox thinker, I'm more of an individualist. I look at the individual. Well, that means I also have to start with myself, right? So I take that individuality very close, very much to my own home. Like, okay, what are my cognitive biases? How am I seeing the world? How am I seeing that individual in my workplace? right? And so in the workplace, nobody can compel you to, well, at least not in the United States, to use certain pronouns or to attend certain events. Excuse me. So don't attend those events and use people's names. That's what I always tell people. You know what your co-workers' names are. Use them, right? It's
Yeah.
it's just mean. It's insensitive and it's disrespectful to constantly use. Oh, okay. So there's their legal name, and then there's maybe the name that they want to be known as until they legally change it if they can where they live. Just use that name. It's a nickname. You use nicknames for people all the time, right? Just use it. It's, in some spaces, and I was in the military and law enforcement, everybody went by their last name. It's so much easier. You can just refer to
Solution.
people. Right? People would just call me by my last name. It's like, you can't misgender the last name, right? So, right. And so it's like, just be respectful. Now, if people are being disrespectful toward you because you aren't abiding by their insistence of compelled speech, well, then that's when things just have to be escalated, or you don't. You just learn how to tolerate your own distress about how that person's treating you. You learn how to regulate your emotions. You get some good mindfulness practice. Make sure you're getting good sleep, plenty of water, good exercise, and you find ways to maybe not have to deal with that person as often, right?
Or you know what? I think another solution, you've already hit on this, but is in maybe a D&I setting, is shifting the focus from implicit bias to cognitive bias, because
right.
cognitive bias, we all have them. And so to the extent that what I'm hearing you say, so correct me if I misunderstood, but what I'm hearing you say is, to the extent that someone else is hostile towards it, maybe the training needs to focus on everyone's cognitive biases.
Mm-hmm. Yeah.
Because the person being hostile has a cognitive bias also towards someone, and vice versa. So I think that that's also a way, moving away from like the implicit bias that we find so often in DEI, is to recognize the cognitive bias, which is a much larger phenomenon that we all experience, regardless of white, males, trans, whatever,
well, and in my DEI trainings, I don't break people up into affinity groups. I'd say, don't do that. Don't break people up into affinity groups, because just because somebody is of a particular race or ethnicity or sexual orientation or gender identity or religious faith, that doesn't mean that they are in lockstep with everybody else who looks or worships or, lives the way they do.
Oh, I like the idea of that too. I mean, affinity is how we're doing affinity, it seems, is very much skin deep, and not in a way how people relate. So yeah, I like that idea of not putting people in affinity groups as a D&I method.
Yeah.
Well, Zander, thank you so much. You've shared so much information. I've learned so much from you in the work that you do. I appreciate you sharing with us.
Absolutely. Thank you.